Today, we will discuss a highly multidisciplinary disease. It spans internal medicine. There's endocrinology, rheumatology. Often, actually, there's a high degree of psychiatric comorbidity. And obviously, I'm here because there's a significant degree of ophthalmic involvement. I have no financial disclosures to discuss. So our objectives today are to identify some of the known and established pathophysiology of the disease and to identify the symptoms and clinical findings of thyroid eye disease, and also to go through some of the currently available treatments. And I will try hard not to be very esoteric and ophthalmic. I'm trying to kind of give some good physical exam teaching points and to sort of direct the non-ophthalmologist with regards to how to approach thyroid eye disease. So basically, in terms of general definitions, so Graves' disease is the broader term, right? It's a term for an autoimmune hyperthyroidism related to anti-TSH stimulating anti-TSH receptor antibodies. And in many cases, there are no significant extrathyroid manifestations. When we say thyroid eye disease, then we are referring to the ocular or orbital manifestations. And there are multiple terms that people use. They say also Graves' ophthalmopathy, or if you want to be really, or Graves' orbitopathy. And then if you want to be really nitpicky, or if you can say exophthalmic goiter. And if you're really nitpicky, you stick with thyroid eye disease, because there are cases where the patient is euthyroid or hypothyroid, and it's not common, and you can't detect any thyroid TSIs or thyrotropin receptor antibodies. So in terms of epidemiology, it's not a particularly, for us, it's common. We see it all the time, multiple times a day, but it's not a particularly common disease in the population. Roughly about 5 to 10 or 3 to 8 per 100,000 in women, less common in men. And the female to male ratio overall for Graves' disease is 3 to 4 to 1, about 4 to 1. But when you get to severe thyroid eye disease, severe proptotic, compressive thyroid eye disease, men are just as common as women, and the prevalence, because people tend to live with this for a long time, is about 1 in 1,000. And eye involvement is found in about 30 to 40% of Graves' disease patients. So most don't have eye involvement. And about 5 to 10% of Graves' disease patients get moderate to severe thyroid eye disease. So in terms of the age distribution, it can happen at any age. It's rare in childhood. The disease tends to become worse in older age. And there's a different pattern of disease that, depending on age, most young people, younger patients, will exhibit more fat involvement, meaning puffy, soft tissue expansion of especially seen in the eyelids. And older patients tend to have more muscle involvement with the significant exophthalmos, double vision due to restricted motility, etc. And we mentioned that it's more common in women, but men, especially older men, tend to have more severe disease. And vast majority of patients are your classic Graves' disease patients who are hyperthyroid, but 5 to 10% are euthyroid or hypothyroid. So I don't just ask when a patient presents with new evaluation for proptosis or suspected progressive proptosis or eyelid retraction. I will fully evaluate them even if they don't have a history of thyroid disease, and if they don't have, or if they have known long-standing hypothyroidism. So in terms of risk factors, the major and most prominent risk factor, and it's also modifiable, is smoking. A number of case control studies have shown an odds ratio of up to about 8. And we try very hard to get patients to stop smoking. And it's not just cigarettes. Any kind of smoking is thought to be implicated, although the studies that were done with cigarette smoking, but marijuana or vaping is also thought to be harmful because of the oxidative stress that is induced. Additionally, thyroid dysfunction, which again is modifiable. My endocrinology colleagues monitor that and address that, and that helps to improve the course of the disease by keeping patients euthyroid. Another risk factor that we are to blame for, but we can address it, is radioactive iodine. So in about 10 to 15% of cases, radioactive iodine, when used as a definitive ablative therapy for hyperthyroidism, induces Graves' disease, either worsening or triggers de novo Graves' disease. And this risk can be very significantly reduced by steroid prophylaxis. The initial protocols were 0.5 milligram per kg per day tapered over 6 months. Later, there were studies looking at even down to 0.1 milligrams per kg per day, tapered over 3 months, and the results seem to be very similar. So it doesn't really necessitate massive steroid exposure. A marker of high likelihood of active disease are high levels of thyroid stimulating immunoglobulins or thyroid receptor antibodies. And there's been some interesting literature on the role of hypercholesterolemia. And there's actually been a small randomized controlled trial we discussed that looks at the effect of atorvastatin on the effectiveness of steroid treatment for active TED. So, second, stuck.
Click onto the screen with the cursor.
Oh, there we go. And so, in terms of the natural history, there's a fairly, this doesn't always hold, but there's a fairly stereotypical course that the thyroid eye disease usually starts around the time that Graves' disease is diagnosed. And the active phase lasts about 1 to 3 years, usually about 18 to 24 months. And the disease stabilizes once the active phase is complete. So I tell most patients that after we've gotten 2 years out, usually what you see is what you get in terms of how it looks and the manifestations, although that's not always true. There's about a 10% chance of a delayed reactivation. And improvement is not uncommon. So we frequently see, especially in younger patients, that who have mild active disease, just with maintaining a euthyroid state and observation that often with long-term endocrine control, that they slowly tend to get somewhat better. And so you don't necessarily, for mild active disease, have to do anything unless there's no evidence that it's rapidly getting worse. So pathophysiology is complex, and it's not really fully understood, but what's thought to be central is the stimulating anti-thyrotropin receptor antibody stimulates both tissue changes and downstream inflammatory changes in the orbits. And research has shown, and this is actually very closely related to one of the newest treatments for this, newest FDA-approved treatments, that there is an interaction between the thyrotropin receptor and the IGF-1 receptor, that they actually are cross-linked and co-localized, and that there's crosstalk between them. And so what happens, one of the major pathways is that the activation of this, let's say, co-localizing TSH and a TSH receptor and IGF receptor activates orbital fibroblasts, causes them to release a variety of pro-inflammatory cytokines, also causes them to differentiate into adipocytes, which also produce pro-inflammatory cytokines, and then this recruits recruits T and B cells, which then continue the chronic inflammatory response. And in chronic disease, basically what you get is the consequences of all this, where you get extensive deposition of collagen and glycosaminoglycans, specifically hyaluronic acid, in the orbital tissues, as well as because of the fat proliferation, you get fat expansion. So pathologically, in TED, we see grossly enlargement of the extraocular muscles and the expansion of the orbital fat compartment. And histopathologically, and I love pathology. If I didn't go into ophthalmology, I would have gone into pathology. What you get, and this is a cross section of an extraocular muscle. So you see the muscle fibers there, and usually they're very compactly. They're together in a very compact arrangement. And what we see between them is this basophilic material and a chronic inflammatory infiltrate with lymphocytes that shouldn't be there. So basically what you see is chronic inflammation and a deposition of extracellular matrix, as we said, hyaluronic acid, hence the basophilic appearance, and collagen, which causes the significant expansion of the muscles. And what's important to note, hyaluronic acid, being a glycosaminoglycan, is highly hydrophilic. So this is very prone to edema. This is one of the reasons why things not only are swollen because of the added extracellular matrix, they're swollen because of a lot of added water. And yes, sir.
The muscle cross sections were very round, and are they normally more angulated?
Yes, and then because they're tightly packed. Here it's very expanded. It's just because it's all very expanded. There was clearly a lot of edema between interstitial edema. So yes, typically they're angulated and they're packed together. So that's exactly right. So talking clinically, so what do these patients present with? By far the most common is symptoms of dry eye. So irritation, grittiness, itchy, burny, foreign body, sand in my eye kind of feeling. That's by far the most common symptom. And then as the disease becomes more severe, people start feeling pain or pressure behind their eyes, pain with eye movements. Then with restricted motility and the muscles being affected, the people start having double vision. Although there's always a dilemma in people with mild disease, and they say, I see double. And then you ask them, is it truly double? Two equivalent images, or is it an image and a ghost next to it? And obviously I will be checking their ocular alignment and their motility. But a lot of the time, if it's just a mild disease patient with dry eye, it can be ocular surface disease, but that's a diagnosis of exclusion. You have to make sure that they're not starting to, that the thyroid eye disease is starting to affect their muscles. And ultimately, in the worst cases, they start to complain of, usually the symptom of compressive optic neuropathy is dim vision. Colors are washed out, my vision's dim. Then we start to really worry and we check color vision. But again, if it's just some variable blurry vision in a patient with mild disease, it's often dry eye. So dry eye is a big thing in thyroid eye disease. Clinically, and we'll go through pictures, I listed it here, and then we'll actually go through the pictures together. Because this is something that you don't need a slit lamp for. You don't need any special ophthalmic equipment. This is something that you can easily evaluate in clinic. And I will go through how I evaluate these because it's actually helpful in terms of physical exam skills and just knowing what to look for. So eyelid edema, erythema, swelling of the lids, lid retraction of various forms, and all these terms I wrote here are actually manifestations of lid retraction because the muscles that, especially the upper eyelid, the muscles that the levator that pulls the upper lid up also tightens like the other muscles. So that's actually a manifestation of the disease itself directly. And orbital fat prolapse, you see new puffiness in the eyelids, resistance to retropulsion. And that's something that I encourage you guys when you're dealing with a thyroid eye disease patient, with a Graves' disease patient, to check and check it on yourselves or your friends. When you touch you have somebody gently close their eyelids. If they close real hard, it doesn't work because then it's all stiff. You gently kind of tap the eye, not even tap, you kind of put your thumbs on the eyes through the eyelid and you just feel them. And a normal orbit should have some give to it. And in thyroid eye disease, it progressively, in severe disease, it becomes very stiff compared to normal. And when the orbits feel tense, that's very worrisome. And it prompts me to worry more that we're getting into trouble with getting at risk of compressive optic neuropathy, and that we have to do something about it. So proptosis, that's fairly self-evident. In the pictures we'll see. Corneal staining, that's from dry eye. The dry eye happens for a variety of reasons. First, just inflammation reduces the quality of the tears. The tears get full, the production goes down, and they're also full of inflammatory cytokines. And also there's more physical exposure of the eye due to the lid retraction. People get conjunctival injection, which is redness of the conjunctiva, and chemosis, which is edema of the conjunctiva, where you get this sort of, looks like a little gelatinous sac that usually sits on the margin of the lower lid. And finally, you get ocular motility restriction when the muscles get severely affected. And ultimately, you get decreased color vision and you can get a relative afferent pupillary defect if there's compressive optic neuropathy, which is asymmetric. Symmetric compressive optic neuropathy, which you often will get, might not give you a relative afferent pupillary defect because both optic nerves are compressed. So we talked about retropulsion, and we're going to talk a little bit about normal eyelid positions. And this is something our brains are trained to notice because we look at people's faces, where our brains are really good at assessing people's faces. We can see 1 millimeter of asymmetry between the two sides easily. But we don't think about it. So the thing to just pay attention to, and this is, so the upper lid sits approximately 2 millimeters below the upper limbus. It varies a bit, but that is roughly where it normally sits. The lower lid sits roughly at the lower limbus. And then the highest point in the upper eyelid arch is roughly at the medial border of the pupil. It varies slightly, but it's very strange for it to be out here. So, and that's, and the question is also how proptosis is measured. I don't think maybe they have these in the endocrinology clinics, but this is an X-ophthalmometer. We push it up against the rim of people's eye sockets, of the lateral rim, the little teeth you see here, they go up against the lateral rim of the eye sockets. And we measure how much the corneal apex, when they're in primary gaze, protrudes from the bony rim of the eye socket. And there's a large normal range. It's 12 to 22 millimeters. It varies by race. In people of African heritage, it can be up to 24. And what is more important is trying to see, is the patient different than they used to be, or do they feel they look different? But we use this to measure the degree of proptosis and follow it over time. In terms of a non-ophthalmic practice, a good way to assess for asymmetric proptosis is the frog's eye view. You kind of you kind of bend down and look at them, or have them tilt their head back, and you look at their eyes and you ask them to look straight compared to their head. And you look at their eyes and compare to where they sit, and that is much more sensitive than looking at them straight ahead. And you can't compare from the side because you see only one eye. So, and here's some clinical examples, and these are ones that patients see when they Google it. But most of our patients look like this, or even less striking than that. The vast majority of our patients have mild disease. So that is why I said to be cognizant of the normal eyelid positions, because most of our patients don't have, obvious see it from the door abnormality. Because I look at it all the time, when I see somebody in the waiting room, I pick up subtle thyroid eye disease because that's what I do all the time. And it's on the street, I pick up subtle thyroid eye disease. But most of our patients look like this. But when you look at this picture here, what you notice is first, the palpebral fissure, the highest point on the upper lid is somewhere about there. So it's shifted laterally. So there's lateral flare. That is highly characteristic of thyroid eye disease. It doesn't happen in too many other conditions. Lateral flare, there's some lateral flare here. The highest point is here, so almost at the lateral limbus. What you also see is that this is fairly prominent fat prolapse for somebody whose eyes otherwise looks like a rather young person. It might be normal for that person, it might not. So you ask. Yes, sir.
When you say fat prolapse, could you expand on that?
Absolutely. I was going to get to that. That's a very important, there's a very important distinction. So this sort of redundant, puffy stuff up here. And the very important thing is how to distinguish it from edema. Edema is this up here. And this down here, this is edema. And So edema is both are very soft. Edema is more superficial. It looks more watery. If you take a flashlight or a pen light and shine it into it, it almost transilluminates. Whereas fat prolapse doesn't. Fat prolapse is a deeper, soft puffiness, and both are really soft. But edema is much more variable. Edema is worse in the morning and better after they've been standing up for a couple hours. The fat prolapse is there all the time, and so it's an important, because edema suggests active disease. Fat prolapse can be anything. It can be active or inactive, because once the fat is there, it's there, and it stays. So this is more representative of the typical patient. And then a minority are the classic severe exophthalmic patients with horrible lateral flare. And what you see here is lower lid retraction, maybe 2-3 millimeters below the limbus, huge lateral flare. You see eyelid edema, which is also kind of erythematous. Edema is often erythematous because it results from active inflammation in this case. Here, the edema has mostly subsided, and what you get is a little bit of fat prolapse. And what you also see here, and it's you can see here this sort of red thing, and it's not the caruncle. This is an ophthalmic nitpicky point. It is actually a piece of conjunctiva called the plica. And there's plical hypertrophy. So they get a little red protruding puffy thing there in the inner corners of their eyes. That is also fairly characteristic of thyroid eye disease compared to other conjunctival or orbital inflammatory conditions. This is one of the famous signs. It's thought to be pathognomonic, and it's not. Actually, lateral flare is much more pathognomonic than the von Graeffe sign. This is the eyes go down, but the lid lags behind the eyelid. So push the patient into down gaze, ask them to look down, and you see that the lids normally go down with the eyes, that lid doesn't. The second thing we commonly see, lagophthalmos, you ask them to gently close their eyes. Almost everyone can completely close their eyes with forceful closure. Gently, like you're taking a nap. That's my phrase. I've learned over the years to have like certain phrases that most people seem to understand what I want them to do. When I say it, that's what I tell them. And you see the eyes so when they sleep, their eyes are cracked open just a little bit. That often gives them a lot of dry eye and irritation. So this is just a number of arrays of pictures to show different patients, and this is kind of to get a sense of how to assess ocular motility deficits. And sort of the striking one is here, where because of tightness of the inferior rectus muscle, this eye, the right eye is all the way down, and it doesn't go up, but it goes down just fine. So it's usually a restrictive deficit, not a paretic deficit. So the eye is tethered tight by the muscle, but the muscle is not weak. And then the rest, they seem to have fairly full motility, though I argue, and a lot of our patients are like this. This eye goes up a little bit higher than the other. So obviously I do this all the time. And I also do formal alignment measurements, but it's something worth looking at. And you compare the two eyes. So the tests that I order, the thyroid function tests have mostly been ordered by the time patients hit my door. Usually a TSI has also been ordered, but there's the option of ordering TSI versus thyrotropin receptor antibody, general panel of thyrotropin. I generally order just the TSI. You increase the sensitivity slightly by adding the TRAB, but the TSI is very sensitive and specific. And I also often I actually base a lot of my decision making on what I clinically see. I personally, and some oculoplastic specialists follow the TSI over time. I follow the patient clinically. I just get a baseline TSI so that if there's some later on in the future, if there's a point where I'm not sure if they're active or they're maybe reactivating, I can retest it and compare it to baseline. Sometimes if the diagnosis is unclear or they're not hyperthyroid or their TSI is normal, but I see a clinical syndrome that looks like thyroid eye disease, I will order the other autoimmune anti-thyroid antibodies. And my first line imaging test is a non-contrast CT. It is really good at delineating the muscles from the fat. and it'll also assess the bony anatomy of the orbit and allow me to assess the orbital apices for any potential compressive findings. And on CT scan, about 70%, up to 70%, depending on which series you look at, of Graves' disease patients have some muscle changes. So even though they don't clinically have thyroid eye disease. MRI, I don't order it very much, but it's useful if you're not sure if they have active disease or not. You'll see enhancement and T2 brightness in the muscles because of the edema, active edema. So what do you see on imaging? This is classic. They probably have it on the medicine boards. They have it on the ophthalmology boards for sure. It's fusiform enlargement of the muscles sparing the tendons. Other orbital inflammatory syndromes, for example, idiopathic orbital inflammatory syndrome, IOIS, orbital pseudotumor, is thought to be tendon involving. It's also rarely, it can cause a pure orbital myositis, but it often goes beyond the muscle. You see it involving surrounding tissues. So you get thickened muscles sparing the tendon, and there's a certain pattern in which the muscles tend to frequency pattern in which the muscles are involved: inferior, medial, superior, lateral, and obliques. So I'm slow it's a good mnemonic. And if, for example, you get just lateral rectus involvement, I will usually biopsy those patients because that's atypical for TED. And then you think of things like, is it lymphoma? Is it some other inflammatory condition? Also, a lot of the clinical picture, are they having pain? Is it swollen? It plays a role there, but often you will biopsy them. But if you see the typical pattern and they're hyperthyroid, it's pretty straightforward. If you see apical crowding, and this is a bone window CT, so it's not the greatest, but the fat clearly delineates. You barely see any fat in these orbital apices. It's all muscle, and you can barely make out the nerve is there. Whereas this is a soft tissue window, so it's not a fair comparison. But the hypoattenuating fat, which you see kind of around the rim of the orbit here, it's basically been displaced out of the orbital apex. When you see that, I worry that something will need to be done. So here comes the clinical activity score we talk about all the time. And you basically have a number of symptoms and findings. I won't read them out to you. That you score 1 point each, and if it's more than this is the EUGOGO, your European Group on Graves Ophthalmology scheme. If you score 3 or more, it's considered active disease. Notice there's the plical edema and hypertrophy because that's a fairly characteristic finding. And then there's also a modified 10-point scale, which adds 3 more items for change over time, for proptosis changes, motility changes, and change in the vision. And there's a EUGOGO scheme for determining the severity of this disease, so the grade. And basically, mild disease is just mild eyelid involvement, maybe a little bit of fat expansion. I don't look at these criteria very much. I look at the patient and I have a gestalt, but in terms of doing clinical trials, they have fairly defined criteria. And then in more severe disease, there's more significant eyelid retraction, lots of proptosis, significant, fat prolapse, and any double vision, any motility restriction makes you moderate to severe immediately. And then sight threatening means there's an optic nerve compromise, and or they can't close their eyes and their cornea is starting to fail, and they'll get a corneal ulcer, maybe perf, and things need to be done at that point. So vast majority, as we said, of mild disease. And if there is sight-threatening disease, as I said, you have to do something urgently. So what do we do? In my case, we still do, although things are changing, most people still do what has been done for the last 6 decades, 1957 decades. So, and it's glucocorticoids, and they've been the mainstay for decades. And there have been a number of small clinical trials showing that IV pulse dose steroids are superior to oral steroids, both in terms of the response rate and also in terms of side effects and tolerability. So the response rate to oral steroids has in the various series and small trials that have been done, been about 50% IV steroids following the EUGOGO, funny acronym, but protocol, which is 500 milligrams once a week for 6 weeks, followed by 250 of solumedrol once a week for another 6 weeks. About an 80% response rate in terms of inflammation and clinical activity score. It doesn't do much for the proptosis. Some series have reported up to 2 millimeters, but it varies. What's been reported varies from 0 to 2. It has a small, gives a small effect, but nothing remarkable. And the ocular motility has been reported to improve in about 60%. Now with steroids, and you guys know this much better than I do, way better than I do, there's all kinds of side effects. I won't list them to you. You know them better than I do, as I said. But I run into trouble because a lot of my patients with active thyroid eye disease are older patients. They're often diabetic. They're often vasculopaths. And I have to put them on high-dose IV steroids, 500 milligrams IV push, IV infusion. And so I will often, if they're a systemically ill person, send them to the ER to get admitted for the first treatment and see if, especially if they're diabetic, especially if they're poorly controlled diabetic. But in younger or healthier patients, I will arrange for home infusions and just tell them to follow up closely with their PCP, maybe to get a finger stick blood glucose machine. And the concern with high-dose IV methylprednisolone is that of fatal hepatotoxicity, severe hepatic necrosis. And that's been reported with cumulative doses of more than 8 grams. So we try to stay with a cumulative dose that's less than that over the course of treatment. And the mortality reported with with high-dose IV methylprednisolone infusions has been about 0.5% and 6% morbidity. So to me, that's non-negligible. So I am, because of an eye problem, which I love eyes, they're important to me, but the rest of the body is in many ways more important. There is a chance we kill people. The year before I was a first-year resident in ophthalmology, someone died on we actually had an ophthalmology floor that somebody died on the floor getting IV steroids. They were admitted for giant cell arteritis, but they died of complications of steroids. So the good thing about steroids is that they're readily available, cheap, easy to start urgently. And that's why when I have somebody with sight-threatening disease, very bad active disease, sight-threatening disease, I send them to the ER to get their steroids. Active disease, which is not sight-threatening, I'll say, let's set you up for an infusion next week, and we start them. And they have a good response rate, 80%. Many of the sight-threatening patients who have compressive optic neuropathy, they actually within a day or two, and usually I won't follow the protocol if it's sight-threatening. I'll give them 2 days in a row of 500 or 2 days in a row of 1 gram of solumedrol. Most of them, about 80%, most of them get better. Their vision improves, their color vision improves, their visual field, if we're able to get one, improves. So the new kid on the block that they've been advertising very heavily is Teprotumumab. It was approved in 2020. There was a hiatus in production because of the pandemic. And it's the first treatment that really has a well-demonstrated effect on proptosis that's available. And it was approved by the FDA for TED, regardless of severity, regardless of activity state, based on 2 clinical trials where a total of roughly 140-something patients received the drug in similar amount placebo. So the FDA gave a very broad indication based on rather small trials, although this is an uncommon disease, so it's hard to make a very big trial. That's understood. Yes, sir.
The placebo group get standard of care with high-dose steroids, or are they true placebo?
They're true. That is what bothers me about this trial, is that they're true placebo. So it wasn't compared to the standard of care. It was compared to true placebo. And in both, the mean proptosis change was about 2.5 millimeters. And in the phase 3 trial, It's about 60, and this, when they say CAS response, when they say 24 being completely inactivated. So about 60% completely inactivated, but if you look at placebo, 21% became inactive. So as we said, many patients improve on their own. The response rate, the number to remember is about 80%, that people get a significant, and the response rate was for this phase 3 trial defined as a 2 millimeter reduction in proptosis. So good response rate. And overall, as we mentioned, the main issue that I have with the trial is it did not compare it to steroids, because steroids have been the standard of care for a long time. So it's administered IV every 3 weeks, 10 mg per kg are the first dose, and then 20 mg per kg, the remaining 7 doses for a total of 8. The reported relapse rate is about 30% at 72 weeks. So not necessarily a permanent fix. And still, if you retreat, and this is all observational, it's all retrospective. If you retreat, most patients still respond to the treatment. And it appears to have an effect in chronic inactive thyroid eye disease in terms of improving proptosis. And they actually, it's an interesting study. It's a retrospective study of chronic inactive patients who received Teprotumumab. So this was likely because of the FDA gave a broad approval, and the patients wanted it, and somehow they were able to get insurance approval for it. So they reported a very high response rate, 90%, with 2/3 improving in diplopia and an average of 3 millimeters of proptosis improvement. I find that a bit surprising that the chronic patients have a better response than the active patients, although that's maybe it is the case, but it's a single retrospective study. So the durability of treatment is unclear, and it's unclear how it holds up head-to-head with steroids, because it wasn't compared to steroids. And likely the proptosis response will be a lot better than steroids. We know that. And also then the next question is, should you do it with steroids? And a lot of my patients actually get steroids, and I've started treating patients with Teprotumumab because it takes 2 months to get approval and get it set up. They've already received 6 doses of IV steroids, and then we switch them to the Teprotumumab. So they usually, by the time they get to Teprotumumab, their inflammation is mostly gone, and then we help their proptosis improve. And what I've seen clinically is in line with what they report in the trials. About 2 to 3 millimeters is what you expect. And some patients do really well, and some don't do so spectacularly. But the side effects are not entirely benign. So what's been reported, and what was reported in the sort of phase 4, right, post-marketing, so hyperglycemia, that makes sense, that it's because it's affecting the IGF pathways. Hearing impairment, IGF receptors, IGF plays a role in mammalian hearing, and there's about a 10% rate of often permanent sensory neural hearing loss. It appears to be mostly in patients with pre-existing hearing loss. So it's been recommended that before initiating it, and then during the treatment course, to repeat multiple audiograms. And it adds to the headache of instituting the treatment, but it is definitely a reported side effect, and it was not noted in placebo. Also common are like taste changes, dysgeusia, that have been reported. The most common by far is muscle spasms, but that is not a serious side effect with the Teprotumumab. Female patients should not become pregnant while on it, not for 6 months after, because the IGF pathway is very important for embryological development. And it's first theoretically highly teratogenic, and there are animal studies showing it's highly teratogenic. And it's incredibly expensive. A vial of 500 milligrams, so that's 10 mg per kg for a 50 kilogram person, right, is $15,000. So for most patients, you need 2 to 3 vials per treatment. you can add it up, plus the cost of infusion, et cetera, et cetera. Teprotumumab is a very promising drug. It's now heavily marketed, but there are a number of reasons not to jump to immediately use it. And maybe I'm boring and conservative in my treatment approach, but I will usually start with them with steroids. And so other agents that have been tried before teprotumumab, there have been small trials trying rituximab, anti-CD20 antibody, for thyroid eye disease that failed steroids. And one showed minimal effect, and the other showed a great effect. Not so much on proptosis, but great on reducing inflammation. And the difference between these two trials was that, at least what they think the difference is that in the one that showed minimal effect, the patients had had thyroid eye disease on average for, it was years, or well over a year or two. And in the other one, they had been diagnosed within a few months prior. So they still had very new onset active disease. So it might have a role in early on in the disease course by basically depleting your B cells and reducing the burden of TSH stimulating antibodies, TSH receptor stimulating antibodies. There's also been a trial on tocilizumab, anti-IL-6 receptor antibody, that shows a high rate. It was a very small trial. Number of patients in each group was in the teens, if I'm not mistaken. And they again did it compared it to placebo in steroid refractory patients. And they showed a significantly higher rate of disease inactivation. There was in terms of other drugs, mycophenolate. There was a trial in China, single trial where they reported a good proptosis response. They did mycophenolate plus steroids versus steroids alone. They did an interesting course of high-dose IV steroids for 3 doses, I think, one back-to-back, day after day, and then a big, large dose oral steroid taper. That was their steroid regimen, and they showed a improved response in terms of proptosis, about 2 millimeters with mycophenolate. This was not reproduced in another study, although mycophenolate, in subgroup analysis in the more active patients, it seems to increase the rate of disease inactivation. So EUGOGO, European group on Graves' ophthalmology, they recommend considering mycophenolate in addition to high-dose pulse steroids as initial treatment. A number of other drugs have been tried for which there's little and unreliable data. Cyclosporine, methotrexate, azathioprine. There was a clinical trial on atorvastatin. And on atorvastatin plus IV steroids versus atorvastatin alone in hypercholesterolemic patients with Graves' disease. And the response rate was a bit higher in the atorvastatin group. Again, a small trial, but they did show a higher response rate. And then there's always the debate, and I think endocrinologists get to talk about this a lot, and also my rheumatologist colleagues maybe also, on selenium. And there have been small trials that showed improved outcomes in terms of less eyelid retraction in patients with mild disease taking selenium for 6 months. This was done in certain selenium selenium deficient or borderline selenium level parts of Europe. The United States is usually selenium sufficient. The thing I tell patients is you can take it for a while to take the recommended dose. And I tell them if you want to do it, if you want to eat Brazil nuts, you can eat 1 nut a day. Brazil nuts are very rich in selenium. So a Brazil nut a day gives you what you need. And a very old treatment that goes with steroids, actually, maybe I should have put it up with steroids, is orbital radiation. It's been around for a long time. It's actually thought at the doses used to be quite safe. It's 20 gray in 10 fractions. And it's usually administered when there's an incomplete response to steroids after a few infusions. It's almost never given without steroids. It's almost never given alone. And it has a response rate of about 60% when added on to steroids, and seems to have its greatest effect on ocular motility with very little effect on proptosis. The one concern of radiation is in people with diabetes or diabetic retinopathy. radiation retinopathy looks clinically looks exactly like diabetic retinopathy. They're actually impossible to differentiate if you don't know the history. So there is likely a common pathway between the two. And there are actually a lot of, just as a side note, radiation necrosis of the brain. Also now radiation optic neuropathy and radiation retinopathy. They're treated just like diabetic, certain aspects of certain manifestations of diabetic retinopathy with anti-VEGF agents, with bevacizumab. It's a lot of the manifestations are due to blood vessel damage followed by angioproliferation. So just to summarize it, I didn't want to give a big laundry list. I borrowed an image that shows how a number of the existing and also newly or drugs in development work. So they're also working on a blocking anti-TSH receptor antibody. And interestingly, just as a side note, some people have been identified who naturally have an anti-IGF-1 receptor antibody. In addition to in Graves' disease, in addition to their anti-TSH receptor antibodies, and clinically in these patients thought to be protective in terms of thyroid eye disease. It's a very small series, but promotion of immune tolerance to the TSH receptor, and a number of drugs acting on the neonatal FC receptor to reduce intracellular recycling of immunoglobulins and hence overall reduce immunoglobulin levels. You have tocilizumab. Nobody knows why statins might work, but there's actually a whole number of drugs. There's an oral small molecule IGF receptor inhibitor that is being worked on. So there's a number of drugs that are in the pipeline. Maybe some of them will make it to clinical trials and to phase 3 trials and clinical use. So to get back to treatment, one of the debates we always have is radioactive iodine versus thyroidectomy. And as an ophthalmologist, selfishly, I tell patients, I prefer thyroidectomy because there is a smaller chance of making your thyroid eye disease worse. But that's my selfish view because the only part of you that I'm dealing with is here. And I know a lot about very little. That's the joke we say about ourselves. And so, but it carries significant surgical risks. So radioactive iodine is in general very safe. Patients are often hesitant about it because it's radioactive. But other than local things like dry eye, dry mouth, it's the risks of RAI are generally very low. So what I usually say, and when my endocrinology colleagues send me a TED patient to evaluate prior to considering RAI or thyroidectomy, if it's mild disease, if it's inactive, you can definitely do RAI. If it's mild active disease, sure, you can do RAI if you want to. And I tell the patients, you just accept a different risk profile depending on which treatment you choose. But you would definitely want to use steroid prophylaxis in that if there's any sign of activity. And then, or in general, even if there's any sign of actual thyroid eye disease, is what I recommend. And in moderate to severe disease, if it's inactive, if it's old inactive disease, you can consider RAI with steroid prophylaxis. And the only time when I really try to say, let us try to do a thyroidectomy is when there's severe active disease or sight-threatening disease, because there are some small series that suggest that it's easier to manage the thyroid eye disease after a total thyroidectomy. And ophthalmic management, I wasn't going to get into the nitty-gritty of the surgeries we do and what we do, but the first line thing is if they have dry eye, give them artificial tears. And then for inactive chronic disease, if it's mild and the patient's not bothered by the appearance of their eyelids, I don't do anything. If they're bothered by it, I correct their eyelids. I always try to wait until their disease is stable and inactive to do these kinds of procedures. I don't want to be treating a moving target in terms of adjusting the eyelids. It makes it harder. And in moderate to severe disease, strongly consider surgery once it's inactive. And in the future, based on at least that one series where there might be a delayed response to Teprotumumab, a response in chronic disease to Teprotumumab, we consider there might be a role for Teprotumumab. For active disease, for mild disease, we watch them closely. We give them selenium because many of these patients will improve. And why put them at risk of steroids or Teprotumumab since they have mild disease? I just watch them closely every 2 months, 3 months. Give them strict return precautions. For moderate to severe active disease, we start them on steroids and consider transitioning to Teprotumumab. And for sight-threatening disease, you have to do something emergently. The most common emergent intervention is emergent steroids, and it usually works. But if that doesn't work, bony orbital decompression, if their eyes are popping out of their eye sockets or they have compressive optic neuropathy, or if their eyes are too exposed, if that's the only issue, you can do a temporary tarsorrhaphy or a partial tarsorrhaphy. And then after you start steroids again, in the next few weeks, you consider Teprotumumab. So this is always on our boards, but this is something that I'll mention as a side note. We usually rehabilitate them surgically in a stepwise fashion because each step affects what you do downstream. So you do orbital decompression first, bony or just fat decompression. After they've healed from that, then you do their strabismus surgery because decompressing their orbits can actually give them double vision and affect their motility. Then after strabismus surgery, you do the eyelid surgery last because adjusting the extraocular muscles can alter the positions of the eyelids. So more recently, there have been publications that have advocated doing it all at the same time. This is not gaining wide acceptance. It's very hard to get it cosmetically good if you do it all at the same time. It's much harder. It's not very hard. It's much harder. And as I mentioned, we like the disease to be inactive one before we do surgery, unless there's an emergent indication. So, any questions for me?